A warm greeting to all. I'm Pauline Sheela Priya, Assistant Professor, Department of Medical Surgical Nursing, Faculty of Biological College of Nursing, Bharat Institute of Higher Education and Research, Chennai. Today I'm going to take a topic on management of burns in medical surgical nursing 2. So the burns are caused by a transfer of energy from a heat source to the body. Heat may be transferred through conduction or electromagnetic radiation. So the burns are categorized as thermal, which includes electrical burns, radiation, or chemical. Tissue destruction results from coagulation, protein denaturation, or ionization of cellular contents. The skin and the mucosa of the upper airways are the sites of tissue destruction. Deep tissues, including the viscera, can be damaged by electrical burns or through prolonged contact with the heat source. Disruption of the skin can lead to increased fluid loss, infection, hypothermia, scarring, compromised immunity, and changes in function, appearance, and body image. So the classification of burns. So burn injuries are described according to the depth of the injury and the extent of body surface area injured. So burn depth. So the burn depth determines whether the epithelialization will occur, or determining the burn depth can be difficult even for the experienced burn care provider. So burns are classified according to the depth of tissue destruction. Under that, the first one is superficial partial thickness injuries or first degree burn. So in a superficial partial thickness burn, the epidermis is destroyed or injured, and a portion of the dermis may be injured. So the damaged skin may be painful and appear as red and dry, as in sunburn, or it may have a blister, very minimal blister. The typical characteristics for superficial thickness burns are mild to severe erythema, that is pink to red in color. There is no blisters, skin will be blanched and painful, tingling sensation, and the pain responds well to cooling when applying ice or cold compress. It will be lasting for 48 hours. Healing will be take place within 3 to 7 days. Deep partial thickness injuries, that is second degree burn. A deep partial thickness burn involves destruction of the epidermis and upper layer of the dermis and injury to deeper portions of the dermis. The wound is painful, appears red, and exudes fluid. Capillary refill follows tissue blanching. Hair follicles remain intact. Deep partial thickness burns take longer time to heal and are more likely to result in hypertrophic scars. So the typical characteristics for deep partial thickness burns are large blisters over an extensive area, edema, red base with broken epidermis, wet, shiny and weeping appearance, which is sensitive to cold air. Healing will take place within 2 to 3 weeks. Sometimes a graft may be needed. So these are certain examples for partial thickness burn to the hand and partial thickness burn due to immersion in hot water. Then full thickness burns or third degree burns. A full thickness burn involves total destruction of the epidermis and dermis and in some cases underlying tissues as well as. So the wound color ranges widely from white to red, brown or black. The burned area is painless because nerve fibers are destroyed. The wound appears leathery, hair follicles and sweat glands are destroyed. So the typical characteristics for full thickness burns are deep red, black, white, yellow or brown area, edema, tissue open with fat exposed, little to no pain, It requires removal of the eschar by escharotomy and skin grafting. Scarring and contractures are likely to develop, and it will take weeks to months to heal. So the following factors are considered in determining the depth of the burn. So how the injury occurred, the causative agent such as flame or scalding or liquid, temperature of the burning agent, and duration of contact with the agent and thickness of the skin. The next classification is classification of burns by causative agents. It's based on the causes, where it is divided into thermal burns, chemical burns. So under thermal burns, it is caused by flame, flash, scald, or contact with hot objects. It is the most common type of burn. Chemical burns. So chemical burns result from tissue injury and destruction from necrotizing substances like chemicals. So it is most commonly caused by acids. So in chemical burns produce respiratory and systemic problems, eye injuries. The clothing containing the chemical should be removed. The tissue destruction may continue for up to 72 hours after a chemical injury. Next, third one is smoke inhalation injury. So it results from inhalation of hot air or a noxious chemical. It causes damage to the respiratory tract. It is important determinant of mortality in the fire victims. So in smoke inhalation, we have three types of injuries. That is carbon monoxide poisoning, inhalation injury above the glottis, inhalation injury below the glottis. There are three types in smoke inhalation injuries. In smoke inhalation injuries, due to carbon monoxide poisoning can cause hypoxia in the tissues, carboxyhemoglobinemia, and finally death. So how to treat the carbon monoxide poisoning? So you can treat with 100% humidified oxygen. So poisoning may occur in the absence of burn injury to the skin. Skin color may be described as a cherry red in appearance. Hot air, steam, or smoke can cause mechanical obstruction quickly, and it may lead to hemorrhage in the bronchus, and finally ARDS, that is adult respiratory distress syndrome. So the signs and symptoms of carbon monoxide poisoning are presence of facial burns, thin nasal hair, hoarseness, painful swallowing, darkened oral and nasal membranes, wheezing on auscultation, edema in the nose and airways, flushing, nausea and vomiting, syncope, coma, and death. Injury below the glottis. The pathophysiology of smoke inhalation, injury below the glottis is, it is related to the length of exposure to the smoke or toxic fumes, resulting in pulmonary edema, may not be appear until 12 to 24 hours after the burn. It will result in decrease in surfactant production and decrease in ciliary action. So the next causative agent is electrical burns. Intense heat generated from an electrical current produce electrical burns. It may result from direct damage to the nerves and vessels, causing tissue anoxia and death. The severity of injury depends on the amount of voltage, tissue resistance, current pathways, surface area, and on the length of time of the flow. So you can see the electrical burns on the hand and electrical burns on the back. Next causative agent is cold thermal injury or frostbite. So it usually affects on the fingers, toes, nose, and ears. So the patient will have numbness, pallor, severe pain, swelling, and edema. So blistering in a warm environment, and handle the tissue carefully. We have to handle it carefully. So what are the interventions can be done for this frostbite? So warm the patient rapidly and continuously for 15 to 20 minutes. Avoid slow thawing and do not debride the blisters. So the third classification of burns by extent of body surface area injured or burned. So various methods are used to estimate the total body surface area burned. Among them are the rule of 9, the London Browder method, and the palm method. Rule of 9. So an estimation of the total body surface area involved in a burn is simplified by using the rule of 9. So the rule of 9 is a quick way to calculate the extent of burns. The system assigns percentages in multiples of 9 to major body surfaces. For adult, head and face it is 9%, anterior trunk is 18 and posterior trunk is 18. Upper extremities are 9%, lower extremities carries 18% and the genitalia 1%. Whereas in children, the head and face is 18%, anterior is 18 and posterior is 18. Upper extremities are 9% and lower extremities are 14%. So rule of 9 charts. Head and neck carries 9% and arms 9%. Anterior trunk is 18 and posterior trunk is 18. Legs 18 and perineum 1. Totally it is 100%. So the second method is London Browder method. It is a more precise method of estimating the extent of a burn in the London Browder method. It recognized that the percentage of total body surface area of various anatomical parts, especially the head and legs, and changes with the growth. By dividing the body into very small areas and providing an estimate of the proportion of total body surface area accounted for by such a body parts, one can obtain a reliable estimation of the total body surface area burned. So the initial evaluation is made on the patient's arrival at the hospital and is revised on the second and third post-burn days because the demarcation usually is not clear until then. So in London Browder chart, the head carries 7 and neck is 2, anterior trunk is 13 and posterior trunk is 13. Right butt is 2.5 and left buttock is 2.5. Genitalia it carries 1. Right upper arm 4 and left upper arm 4. Right lower arm is 3 and left lower arm is 3. So right hand 2.5 and left hand 2.5 and right thigh is 9.5 and left thigh is 9.5. Right leg 7 and the left leg 7. The right foot 3.5 and the left foot 3.5. So totally it is 100%. The third method is palm method. So in patients with scattered burns, a method to estimate the percentage of burn is palm method. So the size of the patient's palm is approximately 1% of the total body surface area. So the next classification is classification based on the extent of burn injury, which was given by the American Burns Association. So under that, the minor burn injury. So in minor burn injury, what are the categories? So the first one is second degree burns of less than 15% of the total body surface area burned in adults or less than 10% of the total body surface area burned in children. Or it may be a third degree burn of less than 2% of the total body surface area, not involving the special care areas, including the eyes, ears, face, hands, feet, perineum, and joints. It excludes the electrical injury, inhalation injury, concurrent trauma, all poor risk patients. Examples, extremes of age and concurrent disease. So these are the categories come under minor burn injury. The second category is moderate to uncomplicated burn injury. So under that we have three categories, that is second degree burns of 15 to 25% of the total body surface area in adults, or 10% to 20% in children, and third degree burns of less than 10% of the total body surface area, not involving the special care areas. Then it also excludes the electrical injury, inhalation injury, concurrent trauma, all poor risk patients, examples of extremes of age and concurrent disease. So these are the categories coming under moderate to uncomplicated burn injury. So the third category is major burn injury. So under the major burn injury, we have second degree burns exceeding 25% of the total body surface area in adults, or 20% in children. All third degree burns exceeding 30% of the total body surface area. Then all burns involving eyes, ears, face, hands, feet, perineum, and joints. Then all the inhalation injury, electrical injury, concurrent trauma, and all the poor risk patients are coming under major burn injury. So what are the effects or systemic responses to burns? So there are local and systemic responses. So burns that do not exceed 25% of the total body surface area produce primarily a local response. So burns that exceed 25% of total body surface area may produce both a local and a systemic response and are considered as major burn injuries. So these systemic responses are due to the release of cytokines and other mediators into the systemic circulation. It includes the following, that is tissue edema, effects on fluid and electrolytes, and blood volume. Then the cardiovascular responses may be decreased cardiac output, hypovolemia, decreased blood pressure, and increased pulse rate. So the pulmonary responses are inhalation injury to the airways, resulting in bronchoconstriction. This is the major cause of death, and acute respiratory failure or respiratory distress syndrome. Then altered immunological defenses and renal dysfunctions. So how to manage a patient with burn injury? So burn care must be planned according to the burn depth and local response and the extent of the injury and the presence of a systemic response. Burn care then proceeds through three phases. We have three phases in burn care: emergent phase or resuscitative phase, acute phase or intermediate phase, and last one is rehabilitation phase. So although priorities exist for each of the phases overlap, and assessment and management of specific problems and complications are not limited to these phases, but take place throughout the burn care. We have a table for the phases of burn care. So the first phase is emergent or immediate resuscitative phase. So the duration is from the onset of injury to the completion of fluid resuscitation. So the priorities in this phase are: we have to give first aid, prevention of shock, prevention of respiratory distress, detecting and treatment of the concomitant injuries, wound assessment, and initial care. The second phase is acute phase. Duration starts from the beginning of the diuresis to near completion of wound closure. The priorities are wound care and closure, prevention or treatment of complications, including infection and nutritional support. The last phase is rehabilitation phase. The duration is from major wound closure to return to the individual's optimal level of physical and psychosocial adjustment. The priorities are prevention of scars and contractures, physical, occupational, and occasional rehabilitation, functional and cosmetic reconstruction, and psychosocial counseling. So in emergent and resuscitative phase management, extinguish the flame and cool the burn and remove the restrictive objectives and cover the wound and irrigate the chemical burns based upon the burn scene. So emergency medical management. So the patient is transported to the nearest emergency department. The hospital nurses and the physician are alerted that the patient is en route to the emergency department so that life-saving measures can be initiated immediately by a trained team. So the initial priorities in the emergency department remain airway, breathing, and circulation, ABC. For mild pulmonary injury, inspired air is humidified and the patient is encouraged to cough so that secretions can be removed by suctioning. For more severe situations, it is necessary to remove the secretions by bronchial suctioning and to administer bronchodilators and mucolytic agents. If edema of the airway develops, endotracheal intubation will be necessary. Management of fluid loss and shock. So fluid replacement therapy. The total volume and the rate of intravenous fluid replacement are gauged by the patient's response. The adequacy of fluid resuscitation is determined by output totals of 30 to 50 ml per hour, systolic blood pressure exceeding 100 mm of Hg, and the pulse rate is less than 110 per minute. So what are the conditions leading to burn shock? So immediately after burn, there is an increased vascular permeability resulting in decreased intravascular volume and increased the level of hematocrit and increased viscosity resulting in increased peripheral resistance. Meanwhile, there will be edema and decrease in blood volume resulting in burn shock. So management of fluid loss and shock. So what are the fluid requirements? So the projected fluid requirements for the first 24 hours are calculated by the clinician based on the extent of burn injury. So some combination of fluid categories may be used. Colloids. Examples are whole blood plasma and plasma expanders, and crystalloids or electrolytes, physiologic sodium chloride or lactated ringer solution. So fluid requirements. So adequate fluid resuscitation results in slightly decreased blood volume levels during the first 24 post-burn hours and restores the plasma levels to normal by the end of the 48 hours. So the oral resuscitation can be successful in adults with less than 20% of the total body surface area, and children with less than 10% to 15% of the total body surface area. So there are guidelines and formulas for fluid replacement in burn patients. So the first formula is consensus formula. So lactated ringer solution or other balanced saline solution will be given for 2 to 4 ml per kg body weight, and it is multiplied with the total body surface area burnt. So half to be given in the first 8 hours and the remaining half to be given over the next 16 hours. The following example illustrates use of the formula in the management of a 70 kg patient with 50% of the total body surface area. There are 3 steps. The first step is using the consensus formula, that is 2 to 4 ml per kg into total body surface area burnt. So 2 into 70 into 50 equal to 7,000 ml for the first 24 hours. So first 8 hours we are giving the half of the dose, that is 3,500 ml. The next 16 hours we are dividing that 3,500 ml or 219 ml per hour. So the second formula is Evans formula. So in Evans formula, we are using 3 solutions, that is colloids, electrolytes and glucose. So colloids 1 ml per kg body weight into total body's percentage of total body surface area burned. The second one is electrolytes, usually saline, that is normal saline, 1 ml per kg body weight into percentage of total body surface area burned. Third one, we are using glucose 5% in water, So 2000 ml for insensible loss. So in day 1, half to be given in the first 8 hours and the remaining half over the next 16 hours. In day 2, half of the previous day's colloids and electrolytes and all of the insensible fluid replacement. So maximum of 10,000 ml over 24 hours, second and third degree. Partial and full thickness burn exceeding 50% of the total body surface area. The third formula is Brooke RP formula. Here we are using colloids, electrolytes and glucose. So colloids 0.5 ml per kg body weight into total percentage of the body surface area burned. In electrolytes, we are using lactated ringgit solutions 1.5 ml into per kg body weight into percentage of total body surface area burned. Glucose 5% in water, 2000 ml for insensible loss. So a Brooke-Harmony formula for the day 1, half has to be given in the first 8 hours and the remaining half over the next 16 hours. So day 2, half of the colloids and half of the electrolytes, all of insensible fluid replacement. So second and third degree partial and full thickness burns exceeding 50% of the total body surface area are calculated on the basis of 50% of the total body surface area. The fourth formula is Parkland formula or Baxter formula. So here we are using lactated ringgit solution 4 ml into per kg body weight into percentage of total body surface area burned. In day 1, half to be given in the first 8 hours and half to be given over the next 16 hours. Day 2, it varies. Colloid is also added. Hypertonic saline solution. So concentrated solutions of sodium chloride and lactated with concentration of 250 to 300 milliequivalent of sodium per liter is administered at a rate sufficient to maintain a desired volume of urinary output. So do not increase the infusion rate during the first 8 post-burn hours. So serum sodium levels must be monitored closely. The main goal is increase the serum sodium level and osmolality to reduce edema and prevent pulmonary complications. So the main nursing management includes infection prevention, wound cleansing, and administering topical antibacterial drugs like silver sulfadiazine 1% and water-soluble creams, silver nitrate 0.5% aqueous solution, mefenide acetate 5% to 10%, hydrophilic based cream, Acticoat, etc. So what are the pathophysiological changes in the early phase, that is 24 to 48 hours of the burn injury? So after the burn injury, from the brain, you have altered mental status, maybe a cerebral edema, an increased pain response, and increased level of ADH. In lungs, if there is an inhalation injury, there will be a pulmonary edema, bronchospasm, bronchorrhea, and acute respiratory distress syndrome. In adrenal gland, there will be increased secretion of aldosterone and cortisol. In skin, there is a non-blanching burn skin, mottled, clammy, and non-burn skin. Then fluid loss through a burn skin, generalized enema in more than 25% of the body burn. In circumferential burn, there will be a compartment syndrome of the chest, abdomen, and the limbs depending on the site of circumferential burn. In kidneys and bladder, there will be a myoglobinuria, oliguria, urine fractional sodium less than 1%. In the circulatory system, there will be a tachycardia, decreased cardiac index, and decreased stroke volume, normal or low blood pressure, and decreased saturation of oxygen, and increased PVR and SVR, and increased hematocrit. CVP will be variable, and metabolic acidosis, Echocardiogram or ultrasound will show small chambers and decrease contractility. So these are the pathophysiological changes in the early phase, that is 24 to 48 hours of burn injury. So how to face this and what other management can be done in the acute phase? So hemodynamically stable through diuresis. Then capillary permeability is restored. And 48 to 72 hours after injury, then goal is restorative therapy. So our major goal is restorative therapy. So focus on infection control, wound care and closure, providing nutritional support, pain management and physiotherapy. So concluded when the burned area is completely covered by skin graft or when the wounds are healed. So how to give wound care? So daily observation, assessment, cleansing, debridement. So appropriate coverage of the graft. So fine mesh gauze next to the graft followed by middle and outer dressing, or you can use the sheet skin grafts must be kept free of plebs, small blisters. Excision and grafting. So eschar is removed down to the subcutaneous tissue or fascia through escharotomy. Then cultured epithelial autografts, that is CEA, is grown from biopsies obtained from the patient's own skin. Artificial skin. So artificial skins are used when there is a life-threatening full thickness or deep partial thickness wounds where conventional autograft is not available or advisable. Pain management. So our opioid should be given every 1 to 3 hours for pain. And several drugs can be given a combination to reduce the pain. And morphine with haloperidol can be given. We can use the non-pharmacological strategies like relaxation tapes, visualization and guided imagery and meditation. So in rehabilitation phase is defined as beginning when the patient's burn wounds are covered with skin or healed and the patient is able to resume a level of self-care activity. So the complications on burns are skin and joint contractures and hypertrophic scarring. So in rehabilitation phase, both the patient and the family actively learn how to care for the healing wounds. So cosmetic surgery is often needed for the following major parts. So role of exercise cannot overemphasize, or constant encouragement and reassurance, and address the spiritual and cultural needs, maintain a high calorie and high protein diet, and provide occupational therapy.